Hello, I am Maria Schonenberg, a pediatric emergency medicine fellow at the University of Florida College of Medicine in Jacksonville. Today I will present implementation of a dual cervical spine and blunt cerebrovascular injury assessment pathway for pediatric trauma patients. Pediatric blunt trauma is the leading cause of death in children, yet can be challenging to clinically evaluate. Cervical spine, CSI, and blunt cerebrovascular injuries, BCVIs, are fortunately rare, but difficult to identify and, if missed, have a high incidence of morbidity and mortality. CT scans are the traditional method of evaluating such injuries, but are associated with future risk of developing malignancy. Physicians are facing a constant struggle to counterbalance the need to reduce unnecessary ionizing radiation exposure, but also to evaluate thoroughly for potentially devastating injuries. A multidisciplinary group developed a combined pathway to evaluate pediatric blunt trauma patients for both CSI and BCVIs. Our hospital sees over 250 pediatric traumas yearly, yet we are not a children's hospital. Therefore, one of the main goals when developing this tool was to make it reproducible so that it could be used in general emergency rooms where most pediatric trauma patients are initially evaluated. This pathway was developed after an extensive literary review of adult and children algorithms for the evaluation of CSI and BCVIs. We included Nexus, PCARN, and the Denver criteria. Based on certain risk factors, the pathway directs clinicians to different imaging modalities, including X-rays, CT, and CT angiography, as well as how to disposition the patient. The tool was rolled out with presentations to both emergency medicine and surgery staff, is available online, and there are printed versions of it displayed prominently in our trauma center and pediatric ED. To study the pathway's implementation, we conducted a single-center retrospective cohort study, which focused on chart review and data collection from our institution's trauma registry from July 1, 2017 to June 30, 2019. The data was divided into pre and post based on the execution of the pathway. The inclusion and exclusion criteria are listed below. Our primary outcome was to determine if there was any change in CT scan utilization. Secondary outcomes were rate of cervical spine X-ray use, incidence of CSI and BCVIs, missed injuries, and length of stay in the trauma center or pediatric ED. A total of 358 patients were included. The mean age of the patients was 8.1 years, ranging from infants to 14-year-olds. The majority presented with normal vital signs, including a normal Glasgow Coma Scale. The injury severity score was determined for every patient as part of the data collected by our trauma registry, and the median ISS was 1.5. Most patients were male, and racial distribution was consistent with the diverse population our institution serves. There was a reduction of CT cervical spine use and an increase of CT angiograms and screening X-rays. A total of 12 CSI and 3 BCVIs were found. Importantly, there were no clinically significant missed injuries. Of those patients who had a CSI, most did not present with altered mental status, and the majority did not complain of neck pain. When applying Nexus criteria, 83% of these patients screened positive. More importantly, all 12 patients were positive for any one PCARN criteria. 7 out of 12 patients with CSIs had positive Denver criteria. Of these, 2 were identified to have BCVI by CTA scans. Those patients with CSIs on average had lower Glasgow Coma scales, higher abbreviated injury scores, and much higher injury severity scores. Of those patients who had BCVIs, 2 had accompanying cervical spine injuries. 10 out of 12 patients had CSIs only. In the current and following slide, you will find a simplified description of these injuries. This table enlists all the CSIs found in our patients. Injuries ranged from mild ligamental lesions to complete cervical spine instability requiring halo placement. Our study found that this combined pathway was successful in detecting these injuries in pediatric blunt trauma patients. By combining validated screening tools such as Nexus, PCARN, and the Denver criteria in a clinical pathway, we were able to detect such injuries and, more importantly, not miss any clinically significant injuries. Our pathway was specifically designed to be applicable to different settings. It requires equipment that is immediately available in most emergency departments and could be readily transferred to institutions that are not part of a tertiary children's hospital. In our institution, our pediatric trauma patients are cared for by both adult and pediatric trained physicians. Therefore, this pathway may also be portable to ER staffed by mostly adult ER trained physicians. as well as surgeons without pediatric surgery fellowship training. Our study's limitations include being a retrospective study performed at a single center. The majority of the data was collected from patients' electronic medical records. We did not include patients who died, non-accidental trauma, as well as patients with a congenital condition that puts them at higher risk for CSI and BCVIs. It is unknown if we missed any clinically silent injuries. In conclusion, our study revealed the successful implementation of a combined CSI and BCVI clinical pathway for pediatric patients presenting for blunt trauma. We did not miss any clinically significant injuries. More work is required to continue to balance the detection of these injuries and to reduce unnecessary ionizing radiation exposure in children. Please find the references utilized for this presentation. In the next slides, you will find an augmented image of our clinical pathway for easier review. Thank you for your time and attention.